following slide next to it. We cannot. Very good. Very good.
Welcome live from the Thorax Center. First of all, let me say that we are very proud and privileged to be part of the Radcliffe Cardiology Live From series. So thank you very much, Justin Davis, for the invitation. Let me first start by presenting my colleague, Roberto Diletti.
Hello,
and there's also Linda Josias, one of our senior nurses, who will participate and help us scrubbed into this case. But we also have technical support from John, from Annemarie. There's also Gerard, another senior nurse. And we have support, audiovisual support by Rakesh Ramdan. So the aim of these live cases is to demonstrate current technology in real practice. And for today, we want to show you bifurcation stenting, but also the use of FFR with bifurcations. So maybe, Roberto, you can give us some feedback of FFR and tell us what we're going to demonstrate today.
Sure. Well, FFR is becoming really largely used in clinical practice, and maybe we can have a little bit of discussion on the background on about this large use of FFR in clinical practice. We can see in this first slide that actually FFR is an index of physiological significance of coronary stenosis. What does it mean? It means that we are measuring a ratio between pressures proximally and distally to coronary stenosis, and we know that when there is a maximal hyperemia, the pressure has a direct correlation with flow. So measuring a drop in pressure means measuring a possible drop in flow distally to a lesion. And that is what we are doing actually with FFR. Maybe we can have another slide where we can see that there are different ways to assess FFR, and for having hyperemia in our patients, what we are using here and what we use usually in the thorax center is adenosine intravenous, and to have a stable signal, a long stable signal for at least 2 minutes. We have this infusion. So, but what we have always tried to understand and to achieve is a clear cutoff to guide our decision during our intervention. And we started having a look at what could be the best cutoff for this decision making. We started with 0.75 actually with FFR, and we observed that with a value below 75, we always have ischemia after a coronary lesion. We have now more and more evidences that are clarifying that actually a value of 0.8 is also very important for us to drive our decision making, and that we could probably use this value of 0.8 to guide our decision in placing a stent and treating the patient or not. So we know that with a value of 0.8, actually we have a reduction in pressure that is 20%. Down the coronary stenosis, and we have a clear ischemic burden there. So maybe we can also have another slide where we can see that there is a correlation actually between what we see currently with our angio and what we have with the functional assessment of the coronary stenosis. And we see that the more the stenosis is severe, the more we are accurate with only angio in terms of assessing the significance of a stenosis. But when we go back towards the lesions that are intermediate, well, our precision, our accuracy in detecting significance of the stenosis is becoming less and less.
So basically it has moved from 0.75 to 0.80, right?
Yes.
So there is some data from the literature, some randomized studies. Maybe we have one study that would claim why it's safe to defer a strategy when the FFR is above 0.75 and maybe even above 8.0?
Yes. So what we have learned is that we have to rely on physiology, and if we don't have a significant lesion from a physiologic point of view, we had better not to treat it. So we have an additional risk in putting a stent in terms of long-term clinical outcomes. So we should rely really on FFR when we have intermediate lesion.
I think it's clear from the graph on the right lower side where you see in blue that if you defer an anatomically significant lesion determined by a stenosis above 50%, but if the FFR is below 75, you only have a 3% rate of MI at 5 years interval. So maybe the key study on FFR, on the value of FFR, was the FAME trial. And the FAME trial was published in the New England Journal a couple of years ago by our colleagues from Eindhoven and Aalst. And this was very impressive, I think. We had a reduction in major adverse events in the FFR-guided group, but also you used less stents and you ended up treating less vessels. So it was also economically very attractive. So maybe without further ado, we could go to our clinical case for today. And our patient is a 51-year-old male with a past medical history of hyperlipidemia, diabetes, obstructive sleep apnea syndrome, and also he already had some stenting done in 2006 of his right coronary and his circumflex artery. At this point in time, he has recurrent angina, and he was admitted to one of the referring hospitals where they did an angiogram. And by angio, it was clear that the patient had a distal left mainstem stenosis. So maybe we can show the angio from the referring hospital. This is the still frame, and this is, these are the cines. You can see that the right coronary only shows some luminal irregularities. And if we then switch to the dynamic cine that they made in the referring hospital, you can really appreciate the distal left mainstem disease. And this is basically where we are today. So the patient was discussed in the heart team, and the discussion went in favor of PCI because we had a calculated syntax score of around 22, and in our practice, syntax score of 22 really pushes the patient towards PCI, at least if it's technically feasible, and especially when we're dealing with left mainstem disease. We know from the syntax study that in particular the patients with left mainstem disease do very well in comparison with surgery if they get PCI. So in this patient, the syntax score was 22. Next. But the syntax score was based on the angiogram by the referring hospital. So we had a conclusion that this was a young patient. He had previous multivessel PCI that had been successful, and now a low syntax score. So the patient was accepted for PCI. And this is where we are today. So maybe we can show the setup. We have a right radial access, where we have a 7 French sheath in place. So this is a 7 French slender sheet. So the slender sheet technology allows us to have less radial spasm. So we have a 7 French left Judkins 3.5 shape. And then we made our angios for today. So maybe we can show the spider view. That was our first angio, and you can see that it is quite a challenging distal bifurcation. And
I must say that when I saw this angio, I was a little impressed, because from the previous angio, from the referring hospital, we had not included we have this angle, so that can make more challenging our
And I must also say that this is maybe the ideal life case patient, but maybe also not, because of the challenging angulation of the circumflex artery, which is more than 90 degrees, as you can appreciate. So what also is quite striking is the amount of calcium that extends into the LAD. And maybe we can show the caudal view, where we have another appreciation of the distal left main. So definitely this is a Medina 111. And then a cranial view. And this was maybe a little bit unanticipated, that also the LAD has some intermediate disease in the mid portions. So I think it's very valid to do an FFR at this point in time, just to determine our proper strategy. Should we limit our strategy to the distal left main, or do we also need to take into consideration the mid LAD? So maybe here an FFR and a pullback measurement would be handy. And maybe, Roberto, you can, as I start doing the FFR, you can explain a little bit the new technology, the new FFR technology that we are using in our current practice.
Sure. So we are using quite an innovative technology that is a microcatheter to assess FFR. And I think in this particular case, as we see, the diffuse disease in the LAD could be very interesting to use this microcatheter. What is like this device? Well, it's actually a very tiny microcatheter. We can see here an image, and we can compare the dimension of the catheter with a normal wire. We can see here an image where we have a specification of what is the dimension of the microcatheter. You see two cross sections of the microcatheter, one on the right and the other one on the left. And you see that on the right is located a sensor that is an optical sensor that is actually assessing the pressure, so it's assessing the FFR. On the left side, you see what is the catheter like more proximally, and actually where is located the stenosis usually. And if you look carefully at the dimension of the catheter, you see that the section of the microcatheter that will go located at the stenosis, it's as dimension that could be comparable with two wires of 0.14 inches. So we thought initially that this dimension could have not a great impact on the flow and on our FFR measurements. So we proceed with the use of this microcatheter, and we made some assessment also in comparison with a normal FFR. You see here some cases that we perform with FFR, standard FFR, and with the microcatheter, and you can see that there is a very reasonable correlation, and also the blunt Altman is very reasonable in terms of values for normal FFR and for microcatheter. So maybe we can also mention another important factor for this microcatheter, that is the signal drift. We have much less signal drift with this microcatheter, and this is due to the technology, to the optical technology of this microcatheter compared with the standard wires. And this is very important when we are doing multiple measurements. So probably we can wrap up briefly before going with the microcatheter in the coronaries, that we have some theoretical advantages with this microcatheter. That is, first of all, you can use the wire that you want to go down in the coronaries, even if you have a very challenging anatomy, and then you can easily go with your microcatheter on the wire. This microcatheter allows you to have multiple pullbacks without losing the access to the coronary. And of course, we can perform FFR after stenting, so we can check our procedure. And finally, of course, what we mentioned is the presence of a much reduced signal drift.
So, Roberto, if you now look back at the spider view that we made today, so if you can show the angio of today again, the first one. So what do you think about this angulation of the circumflex? Do you think that this would be amenable for a conventional FFR wire? Would you even attempt this?
Well, I'm not sure I will attempt it with at first with an FFR wires. I see that there is really an acute angulation, and it's likely to come back the vessel. So I think it would be very challenging with a normal FFR wire to wire this vessel.
Yeah. So this is exactly our strategy for today. We want to demonstrate the value of FFR in more challenging anatomy. So we have a balanced heavyweight wire in the LAD, and we have a whisper wire, so a very hydrophilic coated and a very nice wire to maneuver and to manipulate and to navigate difficult anatomies into the circumflex. So now what I want to demonstrate is, let's see if the microcatheter can take this angulation and go into the circumflex to address the FFR of this vessel. So there are the markers. So now the markers are in, so I know that I'm about to reach the ostium. Here is the ostium of the beginning of the catheter. So this is where we need to equalize, as we normally do with an FFR measurement. And this is very intuitive. There is the console is very easy to use, and we have 1.0, and we are ready to advance. So let's see if we can cross the left main, and it goes. So this is a nice illustration of the ease of the relative ease of use of the Navvus Acist catheter. So we are distal from our lesion in the circumflex. So let's do the assessment. So we start the adenosine. The patient has been informed about potential side effects of the therapy, but we already have a baseline value of 0.72. So I don't know, Roberto, if you still feel the need and the urge to expose the patient to adenosine at this point in time?
Actually not, because if I see this value, I'm really sure that this is of physiological significance.
I tend to agree. So no adenosine, and let's just, I think we proved our point. This microcatheter is really an interesting new technology and will create opportunities for FFR assessment in even very challenging anatomies. So now we have to talk strategy here. So we have a significant distal, relatively complex left mainstem disease. And I think we have to start talking about our stent approach. I think we all know that provisional stenting is the strategy of first choice, but I think in this particular case we have a Medina 111, so there is disease in the distal left main, in the proximal LAD, and in the proximal circumflex. So I think I would be in favor of doing a two-stent technique. Sure. That being said, I'm not sure if a stent will cross that distal carina. So first of all, I would prefer ballooning the ostium of the circumflex. So let's do that with a 2.0 by 10 Pantera balloon. This is a semi-compliant balloon, one of our workhorse balloons in the cath lab today. And let's try and prepare this bifurcation. I think the real challenge will be the stent, right? If I'm not so sure if the stent will take this challenging angulation. Well, the balloon really goes in nicely, so maybe we can start inflating here, Roberto. And let's go to 20 atmospheres. So this is a 2.0. This is definitely undersized. This is 2.0 and store and leeg. And then I think maybe a non-compliant balloon just to optimize our preparation. What do you think?
Sure. Yeah, I think that there is quite some calcium there. So if we go with a non-compliant balloon, maybe we can
so let's go for a 3.0 by 8 non-compliant balloon. Is that also a Pantera? Yeah. Yeah, Pantera. In the meantime, I think we also need to consider our strategy relative to the LAD. What do we think about the mid-LAD portion? This is also something that we could evaluate by FFR and doing a pullback.
Yes, I think we have the technology to do that, because we can maintain the access to the LAD while working, and after the stenting of the left main, we can assess the residual amount of atherosclerosis in the LAD, just doing a pullback there.
Yeah.
So.
Maybe we can do that. The patient at this point in time is perfectly stable hemodynamically. We have an ACT of above 400, so this is nice too. And our non-compliant balloon struggles in crossing this lesion. Huh? So let's see if up. Yes, it goes. So we go a little bit back here. Okay, Roberto, let's inflate. And we go to 10. And then go to 16. And this is a 3.0 by 8. Very nice. And down, store. Let's give it some time to deflate and then do the test and see if it navigates and runs through. Well, this is not easy, huh? So maybe, Roberto, let's inflate again. Go back to 20 atmospheres.
20 atmospheres.
This is 20 and down. We're storing this, and then I'm gonna also pre-dilate the left main with this. Yeah, let's go. Okay, 20. Let's go to 20. This is 20 atmospheres and down. All right. Give it some time to deflate. Nah, this is much easier, much smoother. Okay, so promising. So let's go back in now with the Navvus and assess our LAD. But we know now that we already have inflated a balloon in the left main as well. So this will influence our measurement. So there is no doubt we have to treat the left main. So now we're going to do the FFR to do the pullback from the LAD and see if we have an additional pressure drop at the level of the mid-LAD. This is really different from conventional FFR technology, right?
Yes, this technology, as we said, is an optical technology. So we use an optical sensor that has the advantage to have much less signal drift, as we said before. Mm-hmm. And what I think in this case is really important for us is the fact that we can perform multiple pullback there, mm-hmm. and in the LED, maintaining the wire axis to the vessel.
So I'm back now with the Navvus in the left main, and you see the radiopaque marker there. This is also where the sensor is located. So it's clearly visible on the angio there. So let's equalize again in the left main. John? So, what do you think, Roberto? What is this drift? I don't think so. This is what we see when we retrieve the device out of the patient, right? And then we do see the need to recalibrate the catheter.
Well, actually, not that much. We calibrate one time, and there is not much signal drift. So usually we can perform multiple assessment without having an important signal drift.
Yeah.
And this is very handy, I must say.
Yeah. Okay, this is 1.0. Let's go. See if it crosses. Yes, it does. And so let's now move it to a cranial view to make sure where our starting point will be for our pullback. That's definitely distal to the lesion. And we have 0.58, sorry, 0.60. So this definitely, again, is significant. So let's do the pullback now and see how significant this is. So mind, we are not using adenosine. What's the point? Because we already know it's significant, but we want to see a drift here. We want to see a jump here. So I pull back now, and I know that this is the lesion. Can I get the reference from the cranial view? So I have pulled back now all the way to the level of the diagonal branch, and still I don't see a big jump there.
No, I don't see either. So
I think
we should go back again.
Yeah,
more.
So I think this is maybe a good argument to stay away from the mid-LAD and to focus on the distal left main first. And still, we can reconfirm after stenting of the left main. Now, we are still in the lesion, I think. So let's go back to the tip of the catheter. Up. And now it should be 1.0 or close to 1.0. And I think we have a drift here. So, Johnny, we'll have to recalibrate this. So first of all, let's make sure that we are in the left, at the edge of the left main, not in the lesion. Okay, so let's recalibrate this. Yeah. So this is very important. You really have to confirm that you do not have a signal drift, because otherwise it's very difficult to interpret your results. And again, this is also more user-friendly when you use microcatheter-based technology. And again, we are distal into the LAD. And let's see. Oh, this is interesting, huh? We go back, make sure. I think this was a therapeutic microcatheter manipulation, huh? So it's 0.089 now. So let's see, let's go back, let's do the pullback again, because this is strange.
So Nicholas, but I would like to comment on that, because we have the worst case scenario. So we have some drift, and we are uncertain about the values, but we can easily check again, come back and check again, and we never lose the access to the vessel. So
let's do that again, huh? So now we pull it back to the left main, and then see where we are.
Well.
So the question is now, Roberto, when we would consider changing the catheter, what do you think? I think still we have some time to readdress and reassess, so let's recalibrate.
Yes, we are not
and
in
let's
area,
have another
of
catheter
course,
standby.
So we are not in area, of course, and we have access to the vessel. I think that if we go on again having different values, we should think about changing the catheter.
Yeah.
Maybe the calcium, maybe when we cross the calcium with the microcatheter, could be that we created some damage.
So now it's 0.84. Okay, so you know what? Let's first give some adenosine now, because I tend to believe this value, and we do a proper FFR assessment now, because now we are not positive yet, so we still want to obtain hyperemia at this point. And once we have obtained the hyperemia, we can then do another pullback and see if we have the signal drift, yes or no.
Sure.
Okay, start adenosine. So I think this is a nice illustration of the practicality of this kind of technology. There are some limitations, of course, but especially if you try to assess smaller vessels, don't you think?
Yes. Actually, when we are assessing maybe a vessel less than 2.5, we should be careful. Because we had this first assessment of the correlation with FFR, normal FFR, but still when we have vessel less than 2.5, maybe we should pay a little bit more attention.
Yeah. So we are already at an FFR of 0.6866. Okay, so we are getting there. So this will, again, this is a positive, of course. So let's see where it plateaus. And then we will do a pullback again.
So we know that we are doing this infusion of adenosine for 2 minutes.
In principle,
so
yes.
When we will have...
because otherwise it's also difficult to do the pullback, I think.
Sure. We will have a stable signal, I think, after a while.
But this seems like a
quite stable
value. Huh?
Yeah.
So we go with our pullback. And I like to take it to the diagonal level. That's our first assessment. It's the same, huh? It's 0.6. We're still around that threshold. There is some jump. Okay.
But not that much.
And then go back to the ostium
so we
of the left main. So now we want to have 1.0.
Yes, definitely. Let's see if we have it.
It's again drift, huh?
So we have a lot of discussion about the less signal drift.
Yeah. Well, I think we can dwell on this and we can keep on trying with new catheters and stuff, but I think we do not doubt that this lesion is significant. So I think it's better to proceed to stop the adenosine and to proceed with the PCI treatment. So the Navvus goes out. We've already prepared the ostium of the circumflex. So maybe let's try and advance a stent into the circumflex.
Okay.
So let's go with a 3/0 by 8 synergy. stent. So a Synergy stent is one of the next generation or the newer generation drug-eluting stents with an abluminal coating. And let's see how this one behaves in that left main. So we have been pre-dilating with a 3/8 non-compliant balloon. The non-compliant balloon that had lost its profile still managed to cross into the circumflex. So let's see how this behaves now. Take it back to the caudal view. Here we are. Ah, this is into the LAD. Wow.
But, so Nicholas, what we want to do actually is a T-stenting of this left main, right?
See.
So we want to go in the circumflex with the stent and place the stent in the ostium of the circ. And then after, I think we should probably do a dilatation in the main vessel, in what is our main vessel. So it's in the left main LAD, just to ensure that we can cross easily.
Yeah, so what I like to do in these kind of situations is to have the stent ready in the side branch and have a bumper balloon in the mother branch, in the main branch. And then I will only use that balloon for positioning at first. So then I will not inflate the balloon, but I inflate the stent, I deploy the stent. And then I take out, you can release, then I take out the stent balloon and then I inflate the bumper balloon. There's several ways of doing this. I like this technique in particular. This is nice. So now I would like to have a 3.5 by 10 balloon, and this is going to be a semi-compliant balloon, and that will be the bumper. And then we can work our way up to a complete T stent construction. So we already know that a 3/0 stent crosses the bifurcation into the LAD. So that was
we made that test actually.
I surprised you with that technique. Eh?
Yes, yeah. I was not prepared.
Yeah. Okay. So our patient is perfectly stable. So we are very relaxed at the moment. The balloon goes easily. So I really landed there on the bifurcation, on the carina. So let's go back to our spider view. Can I have the reference of the spider as well? Okay, so this is the stent. So let's go, you have the stent?
Yes.
Okay. So there we go. And as I'm positioning, my bumper balloon enters the LAD. So I go back with the bumper. This is the bumper. Let's put some focus on here. It's guiding. So I must say that our Judkins really does a good job. Gives me the support that I want. It's not too aggressive. I like it. Then we diluted the contrast in the balloon a little bit extra because we're talking here about left main stenting. And I think we are in a pretty good shape here. Okay. So, Roberto, you want to give me a little, or Linda, can you give me a little test here? Testje?
I think we are
okay, let's go. We inflate, or we deploy the stent now. We go to 12 atmospheres. Take it to 14. This is 14 and down, store. I store a lot of my fluoroscopies just to save some radiation.
That is good for us and for the patients.
Yes, it's good for both of us. Indeed, win-win situation, huh? So the balloon is down, patient still is hemodynamically perfectly stable. So now I'm going to take out the stent balloon. There you go. Let's keep it there for a second. And now I want to inflate the bumper. Go ahead.
So we want to ensure that
Go
we can
to
cross
16. So this is 16 and down with the bumper balloon at 3.5. So I have high hopes that our stent will now cross as well. So we'll go for a 4.0 by 16. Yeah. So let's see. Roberto, what do you think about the value of FFR in treatment and strategies of bifurcations?
Well, bifurcation makes our life always a little bit more difficult than the standard PCI. When we talk about FFR in bifurcation, I may say that we don't have a lot of data, but we have some interesting studies. And one is the one that we have here with this slide, where we can see that if we consider the main vessel of a bifurcation and we do FFR of the vessel and we compare with angio and with IVUS also, we see that, as we expect, there is a good correlation between our FFR data and our angiographic estimation of the lesion. But when we go for the side branch, and especially when we have an ostial lesion of the side branch and we want to understand if it is of significance, of clinical significance, physiological significance or not, then this correlation become a little less clear and evident. So what is the message of this data? Well, I think that the message of this data is that we are much less accurate when we try to assess the significance of a lesion in an ostial side branch.
So okay, let's focus on the stent positioning now, briefly. Again, a little test, kind of like this. So let's deploy the stent here and put it all the way to 12 atmospheres. So this is a 4.0 by 16 synergy stent. It goes to 12 and down store. And now we need to post-dilate it, the proximal edge of the stent with a 4.5 non-compliant balloon. So 4.5 by 8.
So I go back to the discussion that we were taking, and so if we consider this, that we are less able to correctly assess the significance of a lesion in an ostial side branch compared with a main vessel, yeah, then a study comparing FFR guided PCI of bifurcation versus angiographic guided PCI of bifurcation will be very interesting. And actually, we have some data on this. There was a study that investigated this kind of issue, and it was quite surprising to me, because actually what we saw in a cohort of 200 patients randomized to FFR-guided PCI versus angio-guided PCIs of bifurcation lesion is that in the long term we had not a real big difference in terms of clinical outcomes. So we were a little surprised to see this data. We were expecting that FFR actually was was giving us a much higher advantage in terms of clinical outcomes.
So we go to 12 atmospheres in the meantime with non-compliant balloon. Very good. So we go a little bit deeper as well? I think so, huh?
Yes.
Yeah. Just a second. Okay, Roberto, go. Yeah. 14 and down. So now there is to complete our bifurcation, we need to rewire the circumflex. So, you know, because we had quite a challenging distal bifurcation, let's keep the wire in. And can I have another whisper wire? Just to make sure that.
So, Nicholas, I think we got a question from the audience, and the question was: is that possible that the drift and the change in FFR values that we had was due to the injection of contrast and the note of saline before our assessment?
I think it's always better to do the assessment without additional contrast in your system, because it will always affect the zeroing of your pressure, and it will always affect you will see that there is your pressure censoring is less accurate when there is contrast exposition there.
So that could be a reason for what we have seen.
Yeah, so this is an excellent question, but sometimes, of course, you want to have some contrast just in order to know where you are, and I think you have to approach it from a pragmatic perspective. But that being said, I do believe it's of value to take that into consideration, that contrast indeed can influence your measurement.
It went quite well.
No, it was a very difficult wiring, Roberto. But this is okay, huh? So I think we are making nice progress. So let's first see if we have a 2O balloon, a fresh 2O balloon that can cross. And can I have the needle again? So what I'm going to do now is just take an undersized balloon, a 2O10, to see if I can cross the stent struts. And then, if we can do that, we can then size up a little bit.
Maybe in the meantime we can finalize the discussion that we started, because otherwise we leave the audience also without understanding the content of what we want to say. We were saying that the bifurcation, that what we have seen with bifurcation in the few data that we have in FFR in bifurcation lesion, is that FFR guided PCI in a small group of patients, 200 patients actually randomized, was not that impressive. So we had not a real big advantage of FFR in this group of patients. And I was surprised, but I try also to understand why we had this data. I think one of the explanation is that the clinical relevance that a side branch has is not always so high. So if we consider main vessel and secondary vessel, the clinical relevance in terms of clinical outcomes on long term can be less affected by the disease in a side branch. Yeah. In a secondary vessel compared with a main vessel disease. Mm-hmm. So we should also take into consideration that probably to really have a good understanding of the advantage of FFR in side branch stenting, we will need a very big trial, because we will need a large number of patients to really detect a difference in this kind of specific setting. In the case that we have today, the story is completely different, I think. What do you think?
Yeah.
We are not talking about a diagonal branch, but we are talking about a bifurcation in the left main. So both branches are of absolute clinical significance. So in this case, I think that FFR is obviously relevant and can help us in the judgment. Yeah. We have, by the way, a slide where we see that even in the left main, maybe the previous slides it was that we had. Yeah, even in the left main, we cannot be 100% sure of our angiographic assessment, as we can see here. The accuracy that we have in detecting significant lesion also in the left main is not really 100%. We have some cases where we think we don't have any lesion there. We have 20 or 40% lesion in the left main, and then we end up with a positive FFR, or vice versa.
And I think another important aspect here is that an FFR evaluation of the left main is not that difficult, but if you would look to an alternative way of invasive evaluation, for instance with OCT, that can become very difficult and very hard to interpret with an OCT, for instance, in drogage.
Sure, sure. Yeah, what we have seen also is that we have a correlation not only with diameter stenosis in terms of angiography, but when we consider, for instance, IVUS, that is giving us other parameters like the minimum lumen area and the plaque burden. This also has an important correlation with FFR, but we are never 100% accurate when we detect this, when we assess this lesion.
Well, talking about IVUS, we are going to do IVUS in principle to finalize this case, because we want to make sure that we have proper stent apposition and stent expansion. Of course, that piece of information you will not get by FFR. So
sure.
I think invasive imaging and hemodynamic invasive assessment can be synergistic and complementary. And I have some struggle here with this 4.5 non-compliant balloon. So why don't we give me a new one? 4.5 non-compliant balloon.
So we are now trying to have an optimization of our results first. And what do you think, Nicholas? We will do now optimization and ballooning of the side branch and also in the main vessel, so probably a kissing balloon. Shall we also have an FFR assessment after the stenting? So we were talking about the fact that if we use IVUS, we can have an idea of the apposition and expansion of the stent. But shall we also do FFR after stenting? Because it's our practice to perform FFR in the majority of cases before stent implantation to understand if we have to implant the stent. But what about FFR post-stenting? It's not that common, I think, and this is probably also important to check our results.
Yeah, I think I like the idea, and I think we will do this. I think this will also enter our practice, that we really want to confirm our stent results by FFR. That may be PCI of the future. So let's first get our balloons in now, because we want to end with a nice kiss. So let's do this. This is the 4.5 non-compliant balloon. And I must say that I prefer a compliant and a non-compliant balloon when I do a kiss. I don't want to really destroy the vessel. Make sure that I stay within some limits. So let's get this thing aligned. Just a second. Okay, let's inflate both and go to 10 atmospheres. And now the fun part. Store, 3, 2, 1, down. So this was a kiss. And now we're gonna do a POT, a POT, proximal optimalization. So what I'm gonna do now is I'm gonna just pull back on the 3O balloon in the circumflex.
So the pot will optimize our stent expansion and also some deformation that we can have with the kissing balloon. So we really want to have an optimal expansion of the stent and apposition in the proximal part.
I must say that I still am a believer in go to 16 atmospheres in final kissing and down. I know that there has been a recent publication shedding some doubt on the routine post dilatation. I must say, if the final kissing is hazardous, I have a lower threshold not to urge and to force myself. So, but I still tend to do it. What about you, Roberto?
Yes, I evaluate case by case, and so we are talking about FFR, and probably when we have residual stenosis or a pinching of the side branch, what do you think about doing an FFR of the side branch to assess it and to guide your decision on kissing balloon? We have seen some groups that actually they are performing FFR in this kind of situation, and they perform the FFR in these pinched side branches, and then they did kissing balloon, and after that they repeated kissing balloon. They repeated FFR, and they saw that the kissing balloon was improving. Of course, that was the meaning of the kissing balloon, the FFR in the side branches. And what they have seen is also that the kissing balloon is effective in maintaining these values of the improved values of FFR over time. We have here a slide where we can see that at 6 months follow-up after performing kissing balloon in side branch with a disease in the ostium and pinching of the ostium after stenting, they maintain the good FFR values over time. So I think that this could be also an interesting strategy when we are in doubt.
But still, I don't think that kissing, the technique of kissing is buried yet. I think also the data from Orniston are still very significant, the bench testing. So it's still in my practice, let's put it this way. So shall we do an FFR of the left main coming from the LAD? I think this is really one of the measurements that would be very appealing in this particular case.
Yes, I must say I'm very curious to see.
Yeah. So still we had the agreement with our surgeons that we would always leave a landing zone for a potential bypass in the future. So we have to try and control ourselves not to end up with a complete metal stenting of the LAD. So let's see. Okay, so first we need to equalize. So let's do that first. Yeah, let's equalize. That's 1.0. Okay.
Is it going smooth?
Very smooth, very smooth.
Good.
Okay, so we have a 1.0. So let's start with adenosine. It's okay, it's okay. Start maar gewoon. And then if this is satisfactory, I think we need to do an IVUS.
Sure.
To make sure that our apposition is good.
I bet that it will not be significant with this baseline value. What do you think?
Yeah, I also have some good feeling here. yeah. But we know already that FFR has some value after stenting, right? So
sure.
There is some data that the higher the FFR value after stenting, the better your outcome will be down the stretch.
Yeah, actually, it is interesting because probably we can a little bit move from the idea that the FFR is a binary value, more or less than 80. Probably we can consider that the FFR is assessing also the overall atherosclerosis in the vessel. So probably it's not the same to have 82 after stenting, 0.82 after stenting, or 0.98 after stenting. So there are two very different situations, and we have some preliminary data that are showing that the long-term result after stenting are really associated with we have while I was talking I just look at the FFR and I see that it's still significant.
That's not a problem. So I think this really tells us that this mid portion of the LAD is significant. So let's do a pullback first. So keep the adenosine going. Our patient is coughing now. That this is a little bit annoying, but this is of course is an effect of the adenosine. So let's bring it back to the left main. It's 1.0, so I think this is a valid measurement. So let's go back in with the 3.0 non-compliant balloon and stop the adenosine.
But okay, this is confirming our idea that post-stenting FFR is has a value also in guiding our decision after stenting, because sometimes
Can you show me the cranial view, please?
sometimes we are very happy about our results and we underestimate the disease that we have there. So
The moving image. So the moving cine. Okay, give me zo'n 3015 non-compliant balloon, een nieuwe. So we're gonna go with a 3015 non-compliant balloon. I'm quite aggressive when I see calcified lesions in my pre-dilatation strategy. So I think we have to consider the lesion there starting at the diagonal branch. I'm not so concerned about the diagonal. I'm not gonna tackle that. I'm not gonna embark in a second bifurcation here.
at least with two-stent technique, I would say.
Well, you know, I think this is definitely the assessment that you need to make, right? How relevant is that diagonal branch? And I think it's fair to say that as compared to the circumflex, it's a no-brainer that the circumflex really is a very significant vessel for this patient, whereas the diagonal branch is rather trivial here. Okay, so let's see. So the good thing is that we have now treated our left main. So this should sail through, and it does. So give me a test. Put a little bit higher up and test again. Okay, and inflate. Take it to 12. And down. Store. So this is 3015. Testje. Oh, that's too much. And again inflate. 16. And down. So, klaar voor and a test. Okay. All right, so we have the 3015 as a reference now. So I think a 30 by 24 will suffice. Stent synergy.
So Nicolas, we are really treating the remaining disease after having treated the most complex and important lesion.
I think this is, you know what, when you have sequential lesions, the interpretation of your baseline FFR can be very challenging, and it's always worthwhile to repeat your FFR measurement after you've tackled one of the lesions.
But
and in this case, I think it's a good thing that we did our confirmation FFR.
I have a question for you. You would have done the FFR without the microcatheter, just using the normal wire after this stenting?
Well, I think I would have considered doing an FFR at the end of the case, yes. Because I was, as we started the case today, we said, well, this mid lesion in the LAD, is this now significant, yes or no? So I think we already had the impression that this could be a challenging lesion. Little test. Up and test again. So this is a little bit of a tricky part, but let's position it there. Go. And then we go to 12 atmospheres. 12. 14. Okay, 14 and down. And then let's go for some nitrates. So I think now the nitrates, and we make an angio, and then we'll see where we are.
I think that the use of a microcatheter is making our life easier in this case, because you know, recrossing a left main stenting to re-perform an FFR after two stent technique.
Not without risk.
Yeah. You could go behind the struts and having problem in going down with the FFR. In this case was very easy, so and fast, I must say.
Okay, are you ready for an
Sure.
angio? Let's go. Looks good, huh? So, do we dare to do another FFR? I think so, huh? Let's go.
Yes, we are doing multiple pullbacks, I think, today, so we are really stressing the technology.
Well, but I think this is...
But we are not stressed ourselves because we can do it easily, so...
Yeah, it is very
I prefer to stress the
straightforward.
technology than to stress myself sometimes, so...
Okay, so in we go. Yeah, los. And then... Okay, so let's see if we still have a 1.0.
Let's have a look of our result.
Nee, ik ben nog niet.
But what we were mentioning before is that after stenting, sometimes you have different values of FFR, and we still don't know what is the
Okay, 1.0.
the optimal value. Of course, we want to have more than 0.8, but we know that we could have different kind of values, even they are negative.
Kunt je flushen?
So this is an estimation in a certain way of the residual disease in vessel. And I see that in this vessel we have quite some diffuse disease. Let's have a look.
Oof. Okay.
So you are adjusting the...
Yeah, I'm trying to get my guide properly aligned. Can you give me a little test now? Well, this looks
aligned.
pretty okay. Okay, so can we start? The adenosine is already running. Okay, that's good. That's good. Okay, so let's wait. Let's give it another 30 seconds.
So you see the values is not really one. So I think we have some remaining disease there. Then of course...
But I think if this is correct, if no pressure drift, I think I'm pretty happy with this heavily diseased vessel.
Sure.
And I mean, we started with an FFR of 0.4 or something, right?
Sure.
And there is some drift, so we have to keep it in, go back in. Yeah. Yeah. So,
Nicholas, I think we have not a lot of time remaining for the live transmission. Maybe we could wrap up our ideas for this case and what we have learned.
Equalize? Well, I think first of all, we tackled quite a challenging distal left main stem disease, and we assessed it properly up front, so we were really confident that this was significant disease. I think we demonstrated that there is new FFR technology that facilitates the execution of an FFR, and it tackles the issues that are remaining with current wire-based FFR technology. I think the procedure itself went very well. I think we are not quite done yet. We are finalizing our case, but this definitely will end up being a perfect result. I don't know if we can see any opportunities to treat the distal LAD. I would recommend not to do that. And this is if we can show the FFR at this point in time. So we did a recalibration, and now it's 0.95. So I think I'm pretty satisfied with this result, and
Yes.
with also this case. So can we show the final angiogram that we made? Well, you know what? Let's do this. We take out the catheter, and then we'll make one final caudal shot. just to make sure that everybody is reassured about the final result of this case. So we haven't done a confirmation spider view, so let's do that. Are you ready?
Sure.
Set. Go. Nah. I think this was it.
Yes.
Thank you very much, Roberto. Thank you, everybody in the room. And thank you very much from the Thorax Center. This was live from the Thorax Center for Radcliffe Cardiology. Bye-bye.
Bye.